Thank you for joining us today for our webinar, Handling the Highs and Lows of Rapid Cycling Bipolar Disorder. I'm honored to introduce our presenter today, Dr. Kriti Sinha. Dr. Sinha received her MD from one of Asia's largest hospitals, VMMC and Safdarjung Hospital in New Delhi, India, in 2016, after which she moved to the United States to pursue residency in psychiatry. Dr. Sinha served as the clinical research scholar at the University of Miami before starting her training in 2017. She is currently the chief resident for psychiatry at University of Missouri-Columbia. She takes a keen clinical and research interest in forensic psychiatry, CL psychiatry, physician health and well-being, narrative medicine, and global health. Dr. Sinha will be working in Virginia Department of Behavioral Health and Development Services as an attending physician from July 2021 while completing fellowship from the MacLean Center for Clinical Medical Ethics at the University of Chicago. She also plans to work in the field of preventive medicine and public health in the near future. Thank you so much for joining us today, Dr. Sinha. You're welcome to get started whenever you're ready.
All right, thank you, Natalie, for that great intro. And I'm very excited to talk about this topic. And it's a privilege to be invited by IBPF to talk about this. So first things first, I have no financial conflicts of interest. This webinar is primarily educational, not a medical advice. If you're in crisis or feeling suicidal, please reach out to your doctor or therapist, your support team, or crisis line. All right, so I'll start my slideshow, my bad. There you go. All right, and everyone can see it?
Yeah, it looks great.
Okay, so this is a graph that has been taken from Global Burden of Disease attributable to mental and substance use disorders in 2010. And we know that mental and substance use disorders account for a lot of healthy life years lost, which we count through daily, which is disability adjusted life in years. And so about in 2010, about 184 million people lost, million years were lost because of mental illnesses or substance use disorders. About 70 million years were lost to disability from depression. 10 million years were lost to bipolar disorder, making it the 6th leading cause of daily loss in patient population between 10 to 24 years of age. Annually, per person in the United States, people lose about $2,000 to $33,000 in treatment for bipolar disorder. And studies have also demonstrated that annual cost for bipolar can range anything between $2 billion to $45 billion for the, in terms of United States healthcare. And of course, we always fear the most extreme psychiatric emergency that as clinicians we face is suicide, and about 1 million suicides, according to 2010 data, was happening globally annually. And again, because of the pandemic, of course, this number is probably going to rise in the near future. So recently we have been talking about bipolar disorder and mood disorders, which we define as a form of spectrum, right? So on one extreme of the spectrum, we have unipolar, what we refer to as major depressive disorder. And on other extreme of the spectrum, we have bipolar disorder as type 1 bipolar disorder. And then we have type 2 and unspecified bipolar disorder as well. And Dr. Phelps, one of very renowned clinicians and researcher in bipolar disorder, is whose slide I took this from, who basically talks about how sometimes DSM-5 or DSM in general can, refer to these disorders in terms of very fixed criteria, which is almost dichotomous, which can be helpful for education and communication and memorization, but not necessarily in diagnosing some of our patients who a lot of times will fall in this green zone or this area of gray zone where they might not necessarily fulfill all the criteria but are still suffering. And that's what makes the diagnosis and treatment of some of these patients very difficult. Right. So this is a graph that I often refer to in explaining basics of bipolar disorder and what each of these terms when we are talking about the spectrum are defined as. So this dashed line is your euthymic phase, which is your baseline phase. You're not having any mood changes, no emotions, you're just at peace. And then you have in your life obviously good times, happy times, maybe a great time with your family, with your loved ones, maybe getting accepted to your dream college. And these are obviously normal emotional responses. And then you have bad times, which are part of your life, like losing a pet, or maybe going through a breakup. And you're allowed to feel bad and allowed to feel down, which are all again normal parts of your life. Hypomania is when patients are, people are more extreme. They're happy, they're elated, they're good, they're feeling really, really good, which is almost uncharacteristic of how they normally feel. And this will be observed by other people. It may not really affect their functioning. It will actually help make people very productive. They will feel very productive. They might accomplish a lot during that phase and they love it. But it's still not, it's not a normal emotional response that most people go through unless, they're having a bipolar disorder. And then subsyndromal depression is like the other opposite of, opposite spectrum, where patients are not, they're not clinically depressed, as we call as major depressive disorder, but they're still having some features of depression. They're having problems waking up or doing their day-to-day activities, feeling poor energy, poor concentration, but not necessarily full syndrome symptoms of major depression, when they can, which can warrant hospitalization and can really, really affect their functioning to the point that they're thinking about, suicidal thoughts. And then mania is a complete extreme of positive, aspect of the spectrum, when they're feeling super elated and they're probably reckless and making really poor decisions, but they're so happy that they, they feel like they can conquer anything, they can do anything. All right, so the DSM-5 has put these disorders under the umbrella of bipolar and related disorders. So for type 1 bipolar disorder, all you need is mania. So if you have any, and we will talk about what mania is, but if you have a manic episode in your life, you get diagnosed with type 1 bipolar according to DSM-5, and that's it. You don't necessarily need to have depression or hypomania in the past. Bipolar type 2, for the diagnosis, you require both hypomania and depression. And that's what makes the diagnosis of type 2 bipolar tricky, because when you're hypomanic, you're still functional, you're probably doing great in your life, and you might never want to see a doctor. You'll probably never see a doctor when you're hypomanic. But when you're depressed, that's when you want to seek care, because it's unpleasant. And that's why a lot of patients with type 2 bipolar can be misdiagnosed with major depressive disorder, the treatment of which is different than bipolar type 2. Okay. Cyclothymia is when patients are having some symptoms of hypomania and some symptoms of depression, not all the criteria. They're not meeting the full criteria, but they're having these episodes of hypomania and depression almost all throughout for a period of 2 years. So it's also a difficult diagnosis to make if you don't know your patient having these, symptoms of mania, hypomania, or depression for 2 years. You might never diagnose them with cyclothymia. And then other specified bipolar related disorder is when patients have some symptoms of hypomania, but not meeting the full criteria, and they may or may not have depression. So that's DSM-5 for different types of bipolar disorder. So we discussed for type 1 bipolar disorders, all you need is mania or manic episode. So what's a manic episode? A manic episode is when patients are having a distinct period of abnormally and persistently elevated, expansive, or irritable mood that lasts for at least 1 week. Either 1 week or patient ends up in the hospital because they're so impaired, they're so uncharacteristic that their family members or the legal team or the police brings them to the hospital. They also have to have increased energy or activity during these period of 7 days. Along with that elevated mood and increased energy, they have to have 3 or 4 out of these 7 symptoms based on whether the mood is elated or whether the mood is irritable. They're normally feeling very grandiose, like they're having a very inflated self-esteem. They need to have decreased need for sleep. They might not have slept for several days, and even despite that, they're feeling super energetic. They're talking too fast. They have to keep talking. They're jumping from one topic to another topic. They're very distractible. They cannot focus on one thing. There's increased goal-directed activity. They're trying to accomplish too many things. They're doing multiple projects together. And they also sometimes can make very poor decisions. They can spend a lot of money. They can be promiscuous. They can be using drugs. And that has a high potential for bad consequences. So all of these things during a manic episode, patients have poor functioning, marked impairment in social occupational functioning to the point that they may get hospitalized. And sometimes they can also have psychotic features when they're out of touch with reality. They might be hearing voices, they might feel paranoid. It has to last for 1 week, or the patients end up in the hospital. So you can see that these are very strict criteria for, describing what a manic episode is. And if patients have a manic episode, they have type 1 bipolar, period. For type 2 bipolar, patients have to have a depressive episode and a hypomanic episode, both of them at least once in their lifetime. And for hypomania, how we describe it, it's pretty much the same criteria as mania, but patients are not in the hospital. They're not necessarily, it's not causing impairment in the functioning. They're actually doing great in their life. It has to last for at least 4 consecutive days, but less than 7 days. The change is normally observable by other people, and they never experience psychotic features when they're hypomanic. Okay. For major depressive episode criteria, it's the same criteria that we use for major depressive disorder, where patients have 5 out of 9 or more symptoms nearly every day, most of the day, for 2 weeks. Every day of 2 weeks, they're having low mood, a depressed mood, or loss of interest or pleasure in things that they used to enjoy in the past. And apart from these 2 symptoms, they're also having problems with sleep. They're either sleeping more, sleeping less. They're eating less. They're almost losing weight, or maybe eating more. They're feeling too agitated, restless, or they're feeling super slowed down, like they have to work too hard to even move their limbs. They're feeling poor, they have poor energy, they're feeling super fatigued, they're feeling worthless, they're feeling guilty, they have problems with concentrating. And sometimes they are even thinking about death, having suicidal thoughts, maybe planning things. So that's how we diagnose, a major depressive episode. And for bipolar type 2, you need to have hypomanic episode and a major depressive episode. And sometimes patients have what we call as bipolar disorder with mixed features. So they can have full criteria for mania or hypomania, but they're also having symptoms of depression. Three out of all the symptoms that we talked about in major depressive episode. And these patients might feel very dysphoric. They have a lot of energy, but they're also feeling very negative, and they have they feel like they're being pulled in, opposite directions, and it's very unpleasant to go through, and it causes impairment in their functioning. It might also require hospitalization. It's tough to treat, and these patients also have a higher risk of suicidality. It's said that lithium is less effective for these patients. They might respond better to valproic acid or other second generation, antipsychotics. So switching gears, coming back to our original, topic, is rapid cycling bipolar disorder. So when did this specifier come? Who introduced it? This was introduced in 1974 by Dunner and Feeve. There were a group of scientists who were trying to, following these set of patients who had bipolar disorder, and they were being treated with lithium. And despite being on lithium, these patients were continue to have these mood episodes multiple times a year. And so the scientists said that, they chose this number 4 arbitrarily. And they said anybody who has more than 4 mood episodes in a year, bipolar mood episodes in a year, they probably are having rapid cycling. And at that time, they said that lithium does not work for these patients. Although it did attenuate, for the course of the illness, the subsequent mood episodes might be less severe, but they were still having those mood episodes. Now it's been 50 years almost since this concept came into the light. And now we know that it's not just lithium, but these patients will be resistant to almost all forms of medications that we have. They will be probably resistant to valproic acid or other antipsychotics that we use as mood stabilizers. So rapid cycling as a specifier was incorporated in DSM-4 for both type 1 and type 2 bipolar disorders. Robert Post coined the terms ultra-rapid cycling and ultra-rapid cycling, okay? So these are the patients who are having multiple mood episodes every month. So ultra-rapid cycling is when patients are having mood episodes, more than 1 mood episode every month. Ultra-rapid cycling or ultra-DN rapid cycling is when patients are having multiple mood episodes every day. And these terms have been in the literature since the 1990s. However, DSM-5, DSM-4, they did not incorporate these specifiers as a diagnostic tool. And we'll talk a little bit more about these later, but these constructs can be controversial because a lot of scientists have said that they do not demonstrate they lack the content validity and discriminant validity relative to other disorders, meaning all the criteria that we need to define a condition or define a disease these specifiers might not be demonstrating that, or they might not be able to discriminate between these 2 disorders. How do we differentiate 2 different disorders? So the main problem with these constructs was that they were not meeting the duration criteria. If you're saying someone is having, multiple mood episodes in a month, we know that we want 2 weeks for depression, we want 7 days for mania, we want at least 4 days for hypomania. So that's where the problem lies, and that's why these 2 terms, ultra-rapid cycling, ultra-rapid cycling, can be controversial. So rapid cycling, which is a known specifier that we use in DSM-4 and DSM-5, is again more than 4 bipolar mood episodes in 12-month period. These episodes are just the same as other regular mood episodes that we see in bipolar. They're meeting the symptom criteria, and they're also meeting the duration criteria, right? We cannot these mood episodes should not be directly caused by drugs, substance intoxication like cocaine or steroids, or other general medical disorder that can also precipitate mania or hypomania or depression. And then these episodes can occur in any order or combination. Some patients can have multiple mood episodes, multiple depressive episodes, one after the other. So if they have 2 mood episodes of same polarity, like hypomania and mania, there has to be at least a period of 2 months of either partial or full remission before we count them as separate episodes. But if they're having episodes of opposite polarity, like depression and hypomania or mania, then there is no need for them to be separated by 2 months of remission. okay? They can fluctuate abruptly from mania, today, and then maybe depression 2 weeks later, and they will be counted as two separate episodes. Right. So these are certain personal accounts of rapid cycling bipolar disorder that I took from IBPF website. So patient X, who experiences several cycles in the same day, feels like her mind is playing tricks on her. She says, you're sad 1 minute, you're hyper the next, you're giddy, and then back to sad. It's very confusing, can be very scary how fast your mood can change and change and change. And then there's a patient Y whose rapid cycling changes throughout the year, and she feels like it's like a large roller coaster, but one that's never ending with highs and lows of unknown duration, height and depth. And then patient Z, who's consistently had around 4 mood shifts, which we call as rapid cycling, feels painful, stressful, scary, dramatic. During my manic episode, I spend a lot, I shut people out, I'm impulsive, and then I cycle into depression. It's a quick transition. So no matter how many mood episodes these people are experiencing, they're all, it's causing a lot of impairment in their functioning for sure. So overall, the prevalence that we have based on the clinical studies, the 1-year prevalence for rapid cycling in bipolar patients is anything between 10 to 20%. So 1 or 2 out of every 10 people who have been diagnosed with bipolar can have rapid cycling. That's just more than 4 mood episodes a year. These individuals will experience more affective morbidity, and they might not really respond very well to the treatments that we have for them at this time. And overall, they will have a more depressive burden. They will experience a lot more depressive episodes, which is common in bipolar disorder, than mania or hypomania. They can also be diagnosed with bipolar at a younger age, so 17 compared to 20 years, which is more common for non-rapid cycling patients. And a lot of these patients are females. So females are more predisposed to having rapid cycling bipolar disorder. So this is a diagram that I often show, and can look too much, but essentially, for any mood disorder, bipolar disorder or major depressive disorder, we know that there's a huge genetic predisposition. There's a lot of genes that we have identified. It runs in families. So there's no doubt that there's the twin concordance. Studies have even shown that the transmission can be up to 90% between twins. So they're genetically heavy disease. And then we have epigenetics, right? It is where environmental stressors and childhood adversity can also create some changes at cellular level. They can change how our genes signal, how our DNA, goes through some chemical changes, which we refer to as methylation, acetylation. And these cellular and subcellular changes can also be transmitted generation through generation. And then these changes can also affect the structure of a brain. Functional changes of our brain can cause dysregulation in the level of neurotransmitters in a brain: dopamine, serotonin, GABA, glutamate. And they can also interact with other other systems of a brain, of a body, like neuroendocrine, your autonomic system, your immunity. A lot of patients with bipolar disorders also have increased, inflammatory markers like CRP, interleukin-6, tumor necrosis factor, and all of these can make them more predisposed to have systemic diseases, right? They can have a higher risk of cardiovascular diseases, diabetes, stroke, autoimmune conditions. That's because all of these, all of these various systems and pathways in a body are interacting with each other. Even though patients with mood disorders primarily present as, emotional, cognitive, psychiatric, symptoms, they are also having systemic manifestations of this disorder. So that's why I feel like bipolar disorder is a multi-systemic disorder that presents as, in the form of multiple symptom domains and not just psychiatric. So as far as rapid cyclic is concerned, we still don't have enough genetic studies done, or really enough evidence to say that it's actually runs in families. While bipolar in general, we know that it runs in families, and there's a lot of genes that we have identified. For rapid cycling, we have not found any, specific genes in linkage studies that we have done. A lot of these patients have a higher predisposition to have diabetes type 2. They can also have menstrual disturbances, postpartum period, or menopausal, changes. Um, and that's why the reproductive cycle, there has been some influence between rapid cycling and some of these endocrinological changes. And that might also explain why females are more predisposed to rapid cycling bipolar. And again, sleep rhythm changes, hormonal cycles, they're all associated with triggering rapid cycling as well. What about thyroid axis? So thyroid has shown association. The thyroid axis dysregulation has been associated with your regular bipolar disorder. So initial studies that they did in 70s and 80s, it tended to show that probably thyroid axis abnormalities related to rapid cycling. And then later on, when studies were done, they were inconsistent. The studies were not great. They were retrospective. There was a lot of bias, confounding, and all that. So and a lot of these patients were also taking lithium, and we know that lithium can cause, hypothyroidism. It can cause thyroid dysfunction. So at this time, the hypothesis is that most patients who have bipolar disorder are probably have latent hypothalamic pituitary thyroid axis dysfunction that is latent till the axis gets challenged by lithium, and that might also result into development of rapid cycling patterns. So, it's like a chicken and egg situation: which came first, which caused what, like a lot of psychiatric, disorders. But that's that's how we explain at this time. MRI studies have also shown that there are structural changes in the brain in general in all bipolar patients, but patients with rapid cycling have more severe changes. So the ventral prefrontal cortex of the brain, which is primarily helping us make decisions on how to react when we are faced with emotional triggers, that's dysregulated. And that's much smaller in rapid cycling patients than non-rapid cycling patients. Other gray matter structures are also smaller compared to healthy controls, including other parts of the brain: anterior cingulate, orbital prefrontal cortex, insula, and parahippocampus regions. And while childhood adversity has a strong role to play in a lot of psychiatric disorders and in bipolar disorder, it's been shown that patients who have rapid cycling have a higher risk, have a higher history of childhood maltreatment in the form of sexual, emotional abuse, or neglect, or family conflict, compared to those who did not have a history of maltreatment. Now, what about antidepressants, right? For the longest time, I think there has been just so much conflicting literature in this area as well, where a lot of studies have shown that, antidepressants actually switch you from to a manic or hypomanic phase and can cause rapid cycling as well. And then there's certain studies that did not show that association, and they felt like, okay, just if somebody is stable on antidepressants, just continue it, don't rock the boat and things like that. So STEP BD, which was the biggest study funded by NIMH for bipolar disorder, that was conducted, and they followed several thousand patients, and they concluded that rapid cycling occurred nearly 4 times more often in patients who were also receiving antidepressants compared with patients who did not. Also, those who were receiving antidepressants had a higher predisposition to, be more irritable, maybe have mixed features, maybe they were more had treatment resistance if they were also receiving antidepressants along with mood stabilizers. So it's also been suggested that maybe the cycle acceleration is an epiphenomenon, right? These patients were already predisposed to have rapid cycling eventually, but they were having a lot of depressive episodes, and the psychiatrist went ahead and started them on an antidepressant, and they eventually developed rapid cycling no matter what. So that's there as well. So at this time, we do not prescribe TCAs and monoamine oxidase inhibitors, which are, older antidepressants, had a lot of side effect burden, but they were also extremely, they inhibited the reuptake of norepinephrine or adrenaline. So that can also trigger a manic switch or a phase reversal. And we definitely stay away from those medications in general, but definitely if somebody has a rapid cycling pattern, we never try to, touch them. SSRIs, which is our newer antidepressants like, sertraline or fluoxetine, or citalopram. These medications, and bupropion, they have a lesser predisposition for a manic switch or a phase reversal or causing rapid cycling. So they should, if they are to be used in patients, they should always be used with a mood stabilizer like, lithium or valproic acid. And they should be used as a short term, not necessarily as a long term, treatment, just to make sure, just to be on the safer side. And they should never be used as a monotherapy. If someone has a history of antidepressant induced mania or hypomania, or is having mixed features, or has a recent history of rapid cycling, they should generally be avoided. I would always educate patients, let them know that, hey, if you want to be on sertraline while you're having bipolar disorder, be aware of these warning symptoms of mood switching or cycle acceleration. This is how, you should be able to call me or should be able to talk to someone in the clinic. I would also educate their family members to know what hypomania mania look like, so that they can report to us and we can, just continue the medication slowly. Kindling phenomenon was also described by Dr. Post to explain, the pathogenesis of rapid cycling. This is often used to describe seizure disorder, where patients, if they have, if they have multiple seizures, then subsequent seizure episodes will be faster and it will be more difficult to treat, because your brain gets conditioned and gets sensitized to developing those seizures. Same way, if you have multiple mood episodes, mania or hypomania, your subsequent mood episodes can come faster because your brain is now, not necessarily getting influenced by triggers or stressors. It's just sensitized to have more, subsequent mood episodes. And again, this is something in the literature. It's a theoretical concept. We have, we have not gone to the extent that, this is definitely the case and this is definitely happening. Patients with just rapid cycling in general will have higher comorbid conditions, other psychiatric conditions. They will have a higher predisposition towards anxiety disorders, whether it's panic, social anxiety, generalized anxiety, phobias. They'll have a higher prevalence for eating disorders, ADHD, OCD, substance use disorders as well. So overall, patients who have rapid cycling bipolar, they will have about 8 times the number of depressive episodes and 9 times the number of hypomanic or manic episodes in their lifetime compared to the non-rapid cycling patients. So needless to say, these patients are, their life is much more difficult. They're having a lot of problems functioning. A lot of females, as we know, they're more susceptible, they're having more depressive symptoms, they're getting more antidepressants, and maybe or maybe not, those antidepressants is further causing, creating this vicious cycle of switching. These patients are getting diagnosed with bipolar at an earlier age, so 16.7 years compared to 20 years in non-rapid cycling, compared to non-rapid cycling patients as well. Most studies say that it's a transient phenomenon. It's not something that will last forever. In fact, one of the study followed up these patients for 12 months, and almost 90% of the patients had their rapid cycling phase had subsided by the end of 1 year. So that's good news. But there are also some certain studies that said that, some of these patients were experiencing this rapid cycling for almost 8 years. So that's a very, very long time. And again, it can occur at any point of a bipolar patient's course of illness, but most commonly it is seen at the onset of bipolar disorder diagnosis. So about 27% of the patients will have it at the, just at the, in their early years of bipolar diagnosis, when they're like 19, 20, 21, when they just got diagnosed and they're having these multiple cycles. And a lot of times there's no real pattern. Some patients can definitely have a period of euthymia or remission between these two episodes. Some patients can have just these, opposite episodes of opposite polarity all throughout, with no period of euthymia. And then some patients have just these mood episodes that has just no pattern. So it can be very, the phenotypically, it can be very different and, can be very diverse for our patients. So mostly these patients will experience depression. So about 90% of the time they're having depressive episodes. And if they're more depressed, they will more likely to have suicide attempts, suicidal ideations, and will have a poorer long-term prognosis compared to their non-rapid cycling counterparts. All right. So general principles of treatment. How do we treat patients with rapid cycling? To be very honest, we don't treat them any very different, or we just don't have very different treatment modalities for patients with rapid cycling compared to non-rapid cycling patients. If we can identify something that's triggering it, that's causing it, maybe they're on antidepressants, we'll try to discontinue it for sure. Mania always warrants treatment, always warrants hospitalization. We know it's not just lithium, but most mood stabilizers, whether they're used alone or in combination, might not completely prevent these episodes from happening, but they will help you reduce the severity and the duration of these episodes. So at this point, I think it's more practical and more realistic to focus on improving the functioning and reducing the frequency, intensity, and duration of these episodes than thinking that these episodes will never happen. Okay. So for mania, we start with one of our mood stabilizers like lithium or valproic acid, and a lot of times we will combine it with a antipsychotic like Abilify or olanzapine or quetiapine or risperidone, because mood stabilizers can take few weeks to bring their full effect. Antipsychotics can help with sedation and can decrease some of those manic symptoms at a much faster rate. So that helps. And then later on, we see that if we need to continue those antipsychotics, or we need, if we can manage patients with minimal medications, that's great. But sometimes some patients do require combinations. Lamotrigine is another mood stabilizer, which we use very commonly for type 2 bipolar disorder, especially if it's been used for depressive phase. And when combined with lithium or valproic acid, it has shown to significantly, reduce future episodes or to reduce the severity of mood episodes. Quetiapine is also FDA approved for almost all phases of your, bipolar disorder, acute mania, depression, maintenance, and that has also is one of the first lines for bipolar major depression based on its efficacy and tolerability. So we do have options, and as clinicians, we always try to look into benefits versus risk ratio and try to mix and match, sometimes making sure patients are compliant, making sure our medications are therapeutic. And it's not like maybe lithium has not reached its therapeutic level, and we don't want to change the medications too fast unless we have given them a full made sure that they have given them a full trial. However, unfortunately, some patients are still refractory despite multiple trials. And at the time, clozapine becomes an option. It's one of our second generation antipsychotic, but it has a lot of side effects and requires monitoring weekly, bi-weekly, monthly, but it's very effective. It's very effective not only for bipolar but also for other psychiatric disorders. And ECT, I know it's a stigmatized mode of treatment, but it can also be very effective for patients, including for rapid cycling patients. And then high dose levothyroxine has also been used for treatment of rapid cycling patients, more treatment resistant rapid cycling patients. So some of the general tips that patients with rapid cycling should follow to prevent the subsequent mood episodes is abstinence from drugs, maintaining good sleep hygiene, getting tested for hypothyroidism if you have not already, and definitely if you're on lithium, get your TSH and free thyroxine levels checked. Exercise caution when you're using antidepressants. Try to stay away from it if you have a history of rapid cycling. But we just don't have enough controlled study to actually examine mood instability on a day-to-day basis as a primary outcome measured by difficult. We just don't have enough studies at this time. Prospective life charting is also a lot of patients use, whether it's manually, and I know there are certain apps out there which can help you record how you're feeling today, whether you feel you're more towards manic side or hypomanic side or depressive symptoms, and that can give an objective picture to your clinicians, especially, and to you, because you might not be able to keep a record of how you're feeling on a daily basis. So that is definitely helpful if you're having rapid cycling, ultra rapid cycling type of bipolar disorder. So this is one of the figures that I've taken from the articles here, and this person, as you can see, she or he was euthymic on Monday, and then was feeling probably hypomanic on Tuesday, Wednesday, a little more hypomanic on Thursday, Friday, and then was crashing, going down, and then was probably going to opposite poles on Saturday, Sunday, Monday. So you can see there were almost 3 mood episodes there in a week. So that does help you and your clinician to keep a track of how you're feeling and whether you are experiencing rapid cycling or not. Psychotherapy is helpful for any psychiatric disorder, and CBT, or cognitive behavioral therapy, is one of the most easily available and commonly practiced type of therapy, which has a lot of evidence to show of improvement in all forms of mood disorders, including rapid cycling bipolar disorders, at least as a short-term treatment. And CBT incorporates psychoeducation that targets your sleep hygiene, your substance use, your stress management, coping skills, medication adherence, prodrome recognition. So if you know all these things, if you're practicing these things, most likely, you will benefit from, attenuating the severity of your mood episodes. Even if you're having them, they'll probably be more manageable and you'll be more functional. And some of the components of DBT, which is a different form of therapy, dialectical behavioral therapy that we use for patients with borderline personality disorders, can also help patients who are having ultra-rapid cycling, including emotional regulation, distress tolerance, mindfulness, and interpersonal effectiveness, which are very core components of DBT therapy. So finally, I would like to spend a little bit of time about why ultra-rapid cycling, ultra-rapid cycling can be controversial, and why they can be confused with what we call as borderline personality disorder. So personality disorder, we know it's a pervasive, debilitating condition where patients are having difficulty regulating their emotions on a day-to-day basis, most likely affected by interpersonal stresses and frustrations. And it's a deviation from their developmental age or from their cultural background, and can cause a lot of dysfunction in managing life or being functional on a daily basis. And it's characterized by chronic mood instability. So borderline personality disorder, more historically, we put personality disorders as access to disorders, right? And it's characterized by chronic mood instability and reactivity. So these patients obviously have problems regulating these emotions, responses to interpersonal environmental stressors, managing their impulses. So the affective instability is a characteristic, it's a baseline characteristic for borderline personality disorder. For bipolar patients, it's a deviation. Um, and when we were going through those criteria, we were talking about elated mood or irritable mood, but we were not necessarily talking about affective instability. But when you're having these mood fluctuations on a daily basis, then you can confuse it with borderline personality, especially if you're listening to it and not necessarily experiencing it. Borderline personality disorder diagnosis has multiple other criteria, right? A lot of these patients will also have a black and white thinking. They will have some splitting. They will feel empty, problems with their identity consolidation, unstable relationships, feeling that they are being abandoned, self-harm behavior, self-injurious behavior, some reckless behaviors. And that's the primary pathogenesis of any personality disorders, mostly childhood adversity. So these characteristics are not necessarily overlapping with the core elements of bipolar disorder that we talked about, where we are talking about this discrete episode of poor sleep and impulsivity or distractibility or pressured speech or like elated mood or irritable mood. So if you're looking at the full picture, we are able to differentiate between these two disorders. But if we are only focusing on mood changes or mood fluctuations, then it's easy to confuse between these two disorders. And a lot of patients with bipolar disorder will have more, as we said, irritable mood or elated mood. If they're depressed mood. They might not be angry. While for borderline patients, anger is, again, one of the core feature of their disorder. The tricky thing is that a lot of patients with bipolar disorder can also have borderline personality disorder, right? So patients who have, let's say, comorbid BPD or borderline personality can be up to 29% in type 1 bipolar and 24% in type 2. And 20% of individuals with borderline personality can also have comorbid bipolar. So they can co-occur, and when they're co-occurring, it can have a negative prognostic factor, because now we're dealing with a personality disorder which needs primarily treatment with DBT-like therapy, and we're also dealing with bipolar disorder where we need medications and mood stabilizers. So a lot of these patients will have a higher, poor inter-episode functioning. They will be complex for sure. They will be complex to treat. And they have a higher rate of substance use disorders as well. So is ultrarapid cycling a valid construct? I think it's still a controversial topic. If we are looking at just mood instability, then we are probably overdiagnosing it for people who have borderline personality or substance use and other things. But if you're looking at a complete symptom constellation, where we are talking about we're talking about mood variation along with speech, language, pressured speech, problems with sleep, agitation, impulsivity, and other kind of grandiosity, all those symptoms, even if it occurs for a few hours but it's very discrete, then yes, then maybe we are looking into rapid cycling, ultra rapid cycling picture. So we still need a very rigorous and a very systematic approach to create a differential diagnosis for patients with affective instability, which is still a difficult thing to do in psychiatry. So overall, I would say rapid cycling is not a diagnosis. It's a criteria for It's not a criteria for diagnosing bipolar disorder. It's a specifier to describe episode frequency. As clinicians, it's important for us to make sure that episode 1 has resolved before we count episode 2, else we are misdiagnosing our patients. It's always important to refrain from alcohol or illicit substances that could destabilize your mood. I would minimize antidepressant exposure if someone has a history of rapid cycling, ultra rapid cycling. Make sure we are not dealing with, thyroid changes or dysfunction. And prospective mood charting can actually help patients when we're trying to gauge treatment efficacy and trying to understand this disorder better. All right. So I hope we have time for a few questions.
Yeah, thank you so much, Dr. Sinha, for that presentation. It looks like we have time to go through a few questions from the audience. So for our first question, someone asked, what is the difference between hypomania and full mania? I have had several hypomanic episodes that lasted for 2 to 3 months. My sleep and appetite were almost zero. Is this normal for full mania?
So hypomania and mania, the criteria is the same. You will have, did you have elated mood, or irritable mood along with problems with sleep? But if it's lasting for several months, I would, like the duration criteria for mania is anything more than 7 days. If it's lasting for several months, I would go towards mania. But you also have to have other symptoms like, impulsivity, distractibility, pressured speech, or like feeling very agitated, or multitasking, or doing things that is very uncharacteristic of you. So all of those criteria have to meet along with the duration, which is more than 7 days for mania. Or if you're so sick that you end up being in the hospital, or someone, takes you to the hospital.
Okay, great. Thank you for that explanation. So for our next question, someone asked, how do you best control a mixed state? I would like to be able to balance and hold down a job, but I struggle with rapid cycling.
So mixed state is when you're having symptoms of hypomania or mania, and you're also having depressive features, right? And as I said, it can be a very unpleasant experiencing because you're feeling super energetic, but you're also feeling dysphoric and down. So treatment-wise, I think you need to be on a mood stabilizer for sure. For anybody who has bipolar disorder, whether it's type 1, type 2, or mixed features, they got to be on a mood stabilizer. Now, which kind of mood stabilizer? Lithium has been a gold standard for the longest time. It's still the gold standard. And if it's something that you have tried already and didn't work for you and was therapeutic, then you can try other, and we have several other options that you'll have to discuss with your doctor, which is the best fit for you. But apart from that, I think being educated about how you're feeling, documenting your mood, if possible, getting a good therapist for as cognitive behavioral therapy to know, to recognize your symptoms, to be able to optimize your functioning while you're having these symptoms is also helpful.
Okay, great. Thank you for explaining that. So for our next question, someone asked, if I choose not to use medication, what are the best tools that I can use to help me on a day-to-day basis?
So the same things that I explained, right? So therapy is a great way. I think there are a lot of therapists out there who are also available by Zoom or teletherapy that a lot of people are doing. I think documentation of your mood chart is important too, making sure that you're getting good sleep, eating well, indulging into good lifestyle practices, trying to have a good exercise, trying to make sure that you're abstaining from excessive drinking or using recreational drugs, when that might also shift your mood and can potentially switch you into a depressive or a manic phase. So those are some of the things that you can do. And of course, being a part of this community will help you recognize some of the other things that other people are doing, and that's helping them as well.
Okay, great. Thank you. So next, someone asked, do you have any data on how effective cariprazine is for people with rapid cycling?
Yeah, Vraylar is a relatively a newer antipsychotic medication, and it has been FDA approved for, for acute mania, for acute depression related to bipolar disorder, along with mixed features. In general, we do not have a lot of data for any antipsychotic for or any medication for rapid cycling in particular, and definitely not for Vraylar. First, it's relatively a newer medication. But I will say that if it's something that if you have not responded to other more conventional antipsychotics like risperidone or Abilify or quetiapine, or if you have not responded well to lithium or valproic acid or tegretol, and you want to try Vraylar, I think you can give it a shot. But we just don't have enough data for most medications, let alone cariprazine for rapid cycling.
Okay, great. Thank you. So for our next question, someone explained that the only medication that's worked for them has been lithium, but they want to know if they should be worried about the long-term effects of lithium on their health.
So lithium, I think the biggest side effect burden that can come with lithium is hypothyroidism, right? And that's why we check TSH and pre-thyroxine levels for patients who are on lithium for a long term. And again, if you have, if you're going through regular monitoring, we are able to catch it very fast, and we can always give you supplemental, levothyroxine for treatment. So if lithium works for you, I would never want to want you to switch to another medication, because we know that we have so much data for lithium, not only for bipolar disorder, for acute symptoms, but also for maintenance. And it is the only one of the medications, along with the clozapine, that actually prevents suicide. It has, a lot of data to show also preventing neurocognitive changes or dementia and things like that as well. So if lithium works for you, I would say just make sure you're monitoring your thyroid levels, and if there is any problem, we can always supplement that.
Okay, awesome. Thank you. So it looks like we have time for one more question. And someone asked, can a person with bipolar 1 live without medication, or is it always necessary to be on medication?
Um, Anybody who has type 1 bipolar disorder, it's risky to be out, to be on not on treatment, because you never know when you're going to have a full-fledged manic episode or a depressive episode. It's not recommended. Um, that being said, I know some patients do not want to be on treatment. If you have been on treatment, if you've been in remission for years, I would say at least 2 years, then maybe talk to your psychiatrist to be off treatment. But and then see how you're doing. But again, these are chronic conditions, unfortunately, just like diabetes. If you're diabetic, you have to be on, your metformin or your insulin. If you're not on it, you will have, complications. Same with bipolar. It's very difficult to say that if you have type 1, you will never have a manic episode. So, if you've been in remission for years, talk to your psychiatrist, maybe decreasing the dose of your medications, but I would not recommend it, because, it's just any manic episode has a lot of liability for you, for your doctor, and it can be very dangerous.
Okay, great. Thank you. So just to wrap up the Q&A, for all of those of you who were asking about where you can revisit this presentation, it'll be available on our website and our YouTube channel tomorrow in case you'd like to rewatch any of it. But that looks like all the time that we have for today. So thank you for everyone who attended and asked your questions. And of course, a big thank you to Dr. Sinha for coming on today and sharing your knowledge with us. We really appreciate it.
All right. Thank you for the opportunity.